My name is Jacob Lønborg. I'm an interventional cardiologist at the Rigshospitalet, Copenhagen, Denmark, also associated professor, and has been investigator in the DANAMI-3 trial. So for this trial, the most important thing was that we extended the follow-up until 10 years. And we have to consider that our patients, they live long time with their stents and with the treatments. So we need to consider how they are doing in long term. And we do not have much data in general about long-term follow-up in our patients. So the most important thing in this trial was that we extended the follow-up until 10 years. And we found that the concept of deferred stenting seemed to reduce the occurrence of hospitalization for heart failure and was particular efficiency in the patients that presented with an anterior STEMI. So there might be some patients that might benefit from this treatment. This trial was a trial that was done 10 years ago, or more than 10 years ago, and it was in patients presented with STEMI. And these patients were randomized to either immediately stent implantation, which is the control or conventional arm, or a deferred stenting strategy. And deferred stenting was done by initial restoration of the blood flow in the infarct-related artery, and then at a second stage procedure for 48 hours later, a stent was implanted. And the whole concept is that deferred stenting will reduce the occurrence of slow flow and also embolization during the index procedure. And both of these phenomena are related to adverse outcome. This year at PCI, I presented on behalf of the DANAMI-3 trial investigators the 10 years outcome. And what we found that there was no overall difference in terms of mortality or heart failure, which was the primary endpoint. However, there were a reduction in hospitalization for heart failure. And we also saw that the patient that presented with an anterior STEMI, and these are the ones with a poor outcome, they might benefit from deferred stenting, as we saw that the primary outcome was reduced with around 40% in this particular patient group. For clinical practice, I do not think that deferred stenting should be a routine strategy. Now we have a large-scale long-term follow-up showing no difference in the primary outcome. However, there are patients that will benefit from deferred stenting, and therefore we should still consider using as deferred stenting strategy in some patients that present with anterior STEMI, maybe long symptom onset, and also a high thrombus burden. This concept of deferred stenting had been tested in 4 trials, and all of them are moderate or small size trials. So if we really want to have an answer of whether to use this strategy, we need a large-scale, multi-center, 4,000 patient trial. But whether this will be done, I'm not sure. It's a big hassle because the patient needs 2 procedures and a lot of centers need to be involved. So whether it will be done, I'm not sure.